and management. Over to you, Lakshmi.
Thank you. I'm going to discuss a case where a patient presented with difficulty in walking. This patient booked with us at 21 weeks and was a late booker. She had 2 previous cesarean births, and this was her 5th pregnancy. There was also 2 other first trimester miscarriages that she had had. She was 33 years of age, but with a low BMI. So that was the most striking feature to see her. Her symptoms were for 6 years, and these had been intermittent. But the first start of the symptoms was in the postnatal period after her very first pregnancy. She was complaining of weak limbs, difficulty in doing her daily activities, and could only walk slowly. And she was also having fatigue. And what could be observed is as she was trying to get onto the examination couch as well, she needed some assistance to do that because of her weakness. In the recent months, there was also increasing dry mouth, loss of appetite, and loss of weight. And there was visible angular stomatitis. In the obstetric history, her very first pregnancy was 6 years prior to her index pregnancy. She had a cesarean birth and a baby that was 2.4 kilogram at 39 weeks. And in the second pregnancy, she delivered at 38 weeks and the baby was 2.6 kilogram. Both these were cesarean births. In the second pregnancy also, she had episodes of weakness, and they remained throughout in the following 6 years, but intermittently. In the first pregnancy, the postnatal period was evaluated and low potassium levels were identified. And hence the working diagnosis at the point of her booking was that this was periodic hypokalemic paralysis. She typically mentioned that these episodes of weakness improved whenever she was taking potassium supplements. She had a 21 weeks booking scan, and this scan for anomalies was reassuring in the absence of any gross fetal abnormalities. However, and with normal uterine artery Doppler and Leica. The baby, however, was growing small in the 5th percentile. The evaluation for her showed her potassium to be low when lab samples were taken, and the potassium was 2.4. There was also high chloride, which was 115, and we can see that her sodium was normal, 134, and the anion gap was 5. Serum vitamin D levels were checked, and this was normal. Her hemoglobin was 103. The kidney function for creatinine was normal, and also was her HbA1c. Urine test showed a pH of 8. So what does all this help us to understand? And before we get to that, I also want to just complete the workup so that we can discuss about the diagnosis. We also did an autoimmune workup, which showed that she was ANA and SSA, anti-SSA positive, but she was SSB and anti-dsDNA negative. And renal ultrasound showed bilateral nephrocalcinosis, which is the dark white spots that you're seeing on both these kidneys. So this situation gives us a working diagnosis now, which is changing from periodic hypokalemic paralysis to renal tubular acidosis, secondary to renal to Sjögren's syndrome. So what is Sjögren's syndrome? Sjögren's syndrome is a condition where the SSA antibodies are predominantly the key antibodies that help us to diagnose. And as you can see, this is the American College and the European collaborative classification. Identifying Sjögren's syndrome based on the specific tests for lacrimal flow and salivary flow is not always feasible. Here we are going by the oral dryness that she is describing and the presence of the SSA antibody. And the most common thing that we as obstetricians encounter is that those with Sjögren's syndrome tend to have more a possibility of congenital heart block. And because it's an autoimmune condition, we have to be watchful for placental dysfunction. What is distal tubular acidosis? We looked at all the results that the patient had. And as you can see, the urinary pH was more than 5.5, which was at 8. And this is because the kidney has a defect to excrete the daily acid, and the typical pH of the urine becomes high. There is also hyperchloremic metabolic acidosis and with a normal anion gap. And that is what these blood tests helped us to establish, but in adults. So the challenge is that the combination of this autoimmune and kidney problem poses for this particular patient is that the physiology of the pregnancy will increase the bicarbonate loss, and unless we supplement appropriately, the chronic acidosis will continue to have an impact on the mother and on the baby. So the treatment that was started for this patient was potassium citrate, and 15 mils was given every day, thrice a day, and also oral sodium bicarbonate as 1 gram thrice a day. The monitoring that was continued in the pregnancy was to keep a specific look at her weight, because she was losing weight, and this was an indication of the uncorrected acidosis and electrolyte imbalance. So she started at 21 weeks with 36 kilograms, and as the correction of electrolytes began to set in, weight steadily improved, and the weight was 41 kilograms by the time she was 34 weeks pregnant. Her blood pressure did not pose any problems during the pregnancy and remained normal, and she had normal blood pressures in her previous pregnancies. The improvement of her general health, including lethargy and weakness, and this was consistent after 32 weeks of pregnancy. Nutritional status of the patient was difficult to maintain because of her symptoms and her poor appetite. For mild anemia, syrup of iron was given. She had normal vitamin D levels, and hence calcium and vitamin D supplements were not given in the pregnancy. Also, because there was nephrocalcinosis, this was not a desirable supplement. Electrolyte monitoring was continued periodically, and we started with a low potassium level, which slowly improved and became normal from 27 weeks onwards consistently. The bicarbonate levels remained low, sodium levels were normal, and the chloride levels remained high. There were two challenges that the fetal surveillance posed. One was the presence of bradyarrhythmias that were noticed when the anatomy scan was done at 21 weeks, and hence she had regular fetal echo and pediatric cardiology reviews. These episodes of bradyarrhythmia completely resolved after 27 weeks when the metabolic status of the patient became more stable. The baby, however, on serial growth showed a slowing of growth, and the last scan at just before 36 weeks showed normal Doppler, but a growth that was just above the 5th percentile for gestation. At 36 weeks, this patient presented with spontaneous preterm labor, and potassium and bicarbonate correction was started intravenously prior to the cesarean delivery. Cesarean was done because of previous 2 cesarean births, and the procedure was uneventful. The patient also had opted for a tubal ligation because her family was complete, and this was performed uneventfully. The baby was 1.98 kilogram, in keeping with a small baby, but the baby was born in a good condition. The arterial pH was in keeping with a non-hypoxic status, and the baby's heart rhythm was normal, and the rate was also normal, and the baby had a 24-hour of close surveillance for heart rate, which remained normal with no arrhythmias at all. And this was the same situation when the baby was followed up postnatally as well. the baby was fully breastfed. Potassium and bicarbonate infusions were discontinued after 24 hours. And by day 1, the patient was able to ambulate without assistance and was feeling physically well with not much weakness. So this case was managed as a multidisciplinary approach because of the presence of autoimmune condition and renal condition. Both the teams were involved, but also the bradyarrhythmia was managed in support with the pediatric cardiologist. And being a preterm and a small baby, the neonatal input was very valuable, as was the anesthetist at the time of delivery. But the important component here was the lab services, because there was need for frequent and regular electrolyte surveillance. And as with any unit, the presence of a good working joint service works with good reception and nursing midwifery staff, which were all valuable parts of this patient's care. In the long term, she was discharged with rheumatology and renal follow-up, and the renal team had planned for 2 monthly electrolyte reviews with continuation of her potassium and bicarbonate supplements on a daily basis. The importance of compliance, both for her own health and to avoid severe complications from electrolyte imbalances, were discussed. So this was the case that was managed, and this gave me an opportunity to look into the literature, see what is the implication. Is it just a rare condition? Is it something that we could have managed better from what the current literature is suggesting? So first, to start with the Sjögren's syndrome, we deal with a lot of lupus, which is a common autoimmune condition in pregnancy. However, Sjögren's syndrome is less common type of an autoimmune condition, but the prevalence of this ranges to be different in different ethnic groups. So as you can see, this study looked at how in the European communities, perhaps the occurrence is less and in 4 to 7%, whereas among those with kidney disease, there is a higher proportion of Chinese, which is 33%, and 50% of Indians who tend to have Sjögren's syndrome. So this is one important finding, because this was a patient of Indian origin. The overall surveillance of prevalence of Sjögren's syndrome is 0.04%, and this doesn't commonly involve the exocrine glands, but lung, kidney, joint, and nervous system can be involved. And this is only in around 15% of the patients who have Sjögren's syndrome. The most common thing, as I mentioned earlier, as obstetrician, is that we are aware that those with congenital heart block tend to have anti-Ro, which is the SSA antibody. And if there has been a previously unaffected pregnancy, then 2% of those with the antibodies can have heart block. Whereas once there is an affected pregnancy, then 20% of the subsequent pregnancies can have a congenital heart block. Though the bradyarrhythmias that this patient had were episodes, there were also episodes when the normal heart rate was seen during the scan surveillance. So this was reassuring, and there was no typical pattern of congenital heart block that was seen in this baby. And this was also substantiated after birth by observing the baby's heart rate and rhythm pattern. This review of literature, which is looking at the GR2 group, where there was 106 pregnancies among 96 women with Sjögren's syndrome, did not show any adverse pregnancy outcomes specifically because of Sjögren's syndrome, but there was a 12% flare of the Sjögren's syndrome related symptoms during pregnancy. Another study reported on the review of literature, where there were 709 primary studies, and among them 33 were suitable, and the miscarriage rate was what was deemed to be a higher complication in pregnancy, with a relative risk of 8.3. Whereas the more recent review about Sjögren's syndrome suggested that there is an increased risk for intrauterine growth restriction, thromboembolic events, preeclampsia, preterm birth, and cesarean births. As far as kidney and Sjogren's syndrome is concerned, there is a range of kidney abnormalities that can occur in those who have Sjogren's syndrome. And it can be a renal tubular acidosis. It can be some rarer syndromes like Fanconi syndrome, Barter's, Gilman, or it can be nephrolithiasis, diabetic insipidus nephrogenic type, or it can be tubular interstitial nephritis. Or there can also be glomerular involvement, but that was not what was happening in this patient. This patient had renal tubular acidosis and also nephrolithiasis. When it comes to renal tubular acidosis, as we saw, Sjogren's syndrome is one of the causes, but the other causes could be toluidine abuse, diabetes, chronic hepatitis, alcoholism. But within maternal medicine, it's also important we remind ourselves that it can be a transient symptom sometimes for women with preeclampsia where there is the renal component, or it can be after betamethasone or heparin administration as well. So to summarize, the key points are, this patient presented with hypokalemia, and we know this is the most common cause for muscle weakness. However, a full workup helped us to identify an underlying autoimmune condition and also the renal complication that she had developed, which was renal tubular acidosis and nephrolithiasis. The pregnancy was monitored periodically with weight gain being an important parameter for her metabolic status. She was also monitored for preeclampsia, which she did not have. She was regularly monitored for electrolytes, and the complications of the connective tissue disorder was mainly the oral symptoms that she developed, and her renal functions did not show any evidence of renal insufficiency during this pregnancy. The electrolytes pose a very big problem because potassium levels can actually result in mortality itself. So I think that is something that we should be very clear in explaining to the patients, because in this particular situation, the intermittent therapy was because she felt, even though she had weakness, she was managing somewhat. But it has also got a mortality impact if the electrolytes are not corrected correctly. Also, the chronic hypoxia can set in for the baby because of the acidosis. There can be growth and developmental delay that can happen because of this. And for the mother, there can be significant rhabdomyolysis and also hyperparathyroidism. This patient was evaluated and there was no hyperparathyroidism noted. In the long term, the follow-up is very important, as we mentioned, because of also the mortality risk, but also infections, especially urinary infections. And in this particular patient, the presence of nephrocalcinosis can all quickly bring on a renal insufficiency. And the electrolytes have to be regularly checked for avoiding these complications. Also, those with Sjogren's syndrome tend to have lymphomas. So ongoing surveillance for this is important. Thank you. And we will now discuss about this case.
Thank you, Lakshmi, for that nice case presentation. So just to set the ball rolling, the evaluation for Sjogren's was done as a part of the evaluation of the causes of RTA. Am I correct?
Yes, yes.
And the heart block, that the first two pregnancies, there was no actually heart block for the babies. And that bradycardia that was seen was transient and didn't actually, because you're then, you could have a concern whether this baby was also then developing a heart block, but you said that was not to be. Okay.
Yes. And I think the main theme we could identify was the first baby was somewhat small in size, but both the babies did not have any features of heart issues from rhythm, either during that pregnancies or from how she's describing it currently.
Yeah. Hari, any input?
Yeah. Am I audible?
Yeah. Yes.
Yeah. Okay. So renal tubular acidosis is something not that we commonly come across. In fact, it's rare to see women with renal tubular acidosis in pregnancy. I would have hardly seen a few cases. So it's actually it's challenging both in terms of diagnosis and management. in pregnancy, especially diagnosing renal tubular acidosis and management during pregnancy does pose a lot of challenges. This patient fortunately had a good outcome. Um, her potassium and then acidosis were well maintained. When we see a patient with chronic or recurrent hypokalemia, we need an algorithm approach to get to the diagnosis of what is causing it. So first thing we see is the patient has low potassium. Is it because of renal pathology, renal loss, renal tubular loss, or extrarenal because of GI losses? Patient with recurrent vomitings and diarrhea, patient with malabsorption, that gives us a clue towards GI losses. Whereas in renal, there is no history suggests of GI loss, and we need to demonstrate excess loss of potassium through renal tubules. We could use urinary spot potassium to urinary spot creatinine ratio. We can measure 24-hour urinary potassium. So there's something called TTKG that will tell us that the patient is indeed having renal potassium loss. Once the patient has a renal, we demonstrate renal potassium loss, then next thing we see is the patient normotensive, hypertensive, whether the patient has metabolic acidosis or metabolic alkalosis. In this case, the patient had recurrent hypokalemia and metabolic acidosis. That's why the possibility of renal tubular acidosis was thought of, and that turned out to be distal renal tubular acidosis, that is uh, type 1. So there are some conditions where they have hypokalemia and they have metabolic alkalosis. There we think of Liddle syndrome, Gitelman syndrome, or Bartter syndrome. So that's what we look at, is the patient normotensive or hypertensive, and the patient has acidosis or alkalosis. That gives us clues towards the diagnosis.
My only experience is one lady who had renal tubular acidosis. She presented with a mid-trimester pregnancy loss the first time and came to us for the second pregnancy. But the trouble she had, actually, she had to relocate because in that small village where she lived, getting electrolytes done frequently, monitoring, she found it very difficult. So they actually moved into a nearby larger city for the initial part of the pregnancy and then moved into Chennai closer to delivery. So the frequency of monitoring becomes important. Since you mentioned about the need for good labs and good coordination, I thought it is a challenge.
Yes, because I think especially for somebody like this patient, Uma, we discussed, because she's had years of symptoms, and there may be that feeling of things will remain like this, but it is just that the electrolytes can, actually bring on a mortality risk itself when they are abnormal. So, and the lab should be both reliable and prompt in reporting, because no point in having a low potassium, which is then reported 1 or 2 days later because of the lab systems, isn't it?
Absolutely.
Absolutely. It's a very important access that these patients need.
So, is there a genetic, do we test these women for any, is there a risk? Because this is something that may come up. Is this something that can be inherited? I think there are genetic associations noted, but I'm not sure we can actually test for it in pregnancy. And is there a risk of transfer? I'm not entirely sure.
There are 2 types, Uma. There are less common genetic conditions. There are about 3 mutations, of which one is autosomal dominant, and I think 2 of them are recessive. But these are rare conditions. And really, I think given the rarity of the condition, really to explore it further and look at the genetics is always going to be beneficial, isn't it? So that, especially in a pregnancy situation, to see what the implications will be for the future generations also can be then explored. In this patient, we had not explored the genetic component at all, but there was one other patient that subsequently came for pre-pregnancy counseling, who had an autosomal type, dominant type of variant that was identified. And that patient subsequently did not attend for follow-up. Okay. But definitely that is something we have to bear in mind.
Okay. Yeah,
So
just
that's totally a different entity, isn't it, ma'am? It's not Sjogren's related. It's
It is
another
not,
form
sorry.
of renal tubular acidosis, which is
yes,
a hereditary form, which is a very rare condition.
yes, yes.
Yes,
Not
yes, that's right.
talking
Yeah,
of Sjogren's
not of
related.
Sjogren's. Yeah, yeah.
For
Since
the
we are
renal tubular.
talking renal tubular acidosis,
Acidosis, yes.
I
Yes.
just thought to complete the,
Yeah, yeah, yeah. Just
because nowadays, yeah, it's something that families do ask, isn't it? For any condition, they ask, can we find out, does it run in the family?
yes.
So I thought we'll just close the loop on that as well.
And Uma, I think also when it is a medical disorder that's very complex, there is a stigma on these patients, isn't it? Because especially like what you're saying, when they're living in remote areas, coming repeatedly to even see a doctor can be a barrier because of the social pressures. And I think when it becomes something which is potentially genetic, there is also more of that what if and why it came. These questions have to be addressed as part of the discussions, isn't it? Yes. So it is for renal tubular acidosis that we are talking, that there may be a small component of genetic association.
So appropriate nutritional advice as well, I'm assuming, needs to be given because
Yeah.
of the initial weight. Though the weight did pick up once we corrected,
Yeah.
need some focused nutritional advice.
Yeah.
Good.
Dr. Hari, what can be done for the dry mouth symptoms? Is that, I know those with the dry eyes have, artificial tears and things like that, that can be given to put as eye drops. What is done for usually the oral symptoms?
Uh, Actually, if the Sjogren's, the Zika symptoms are difficult to treat. As you've mentioned, for eyes, you have those the refresh tears, the lubricant drops are available. So we generally advise them to have a sipper, with some water, some lime kind of a thing. And we have some preparations which are commercially available, like the tear supplementation. They do have some sprays, aqua sprays. They are available in some of the pharmacies. So they usually some of our patients carry them whenever they have the dryness. They just spray it in the mouth. Otherwise, they usually carry a bottle and they just keep sipping water. The medications, whatever be it the drugs which we use for the autoimmune diseases, they don't help Zika symptoms much. It's more of a symptomatic treatment.
Yes. Actually, that's what this patient said. Each time I'm taking it, my mouth is still so dry. Why should I take? That was definitely something this patient also mentioned. And but like what you're saying, I think these oral preparations is something we could have tried for this patient to make her feel, that she can comply more, which we did not try. Yes.
Okay, I think if there is no other discussion point, we can wrap up now and then, of course, take questions from the audience as for both the cases that we have presented in this webinar. So thank you very much.
Thank you.
Hello, everyone, again. Really interesting cases. And thank you very much, Dr. Uma, Dr. Lakshmi, and Dr. Hari. It's been very, it's like going through a story, the complete history of what happened with the outcome. I think we'll now do the quiz, Dr. Lakshmi, and then take the Q&A because there's, it's going to take a few minutes before we can actually give out the answers and the results. So I'll quickly share my screen and we'll finish the quiz first. So I think everyone can see this. So this is sorry, again, there's some problem with this. Let's click by itself. So yeah, so just for the participants, this is a short quiz. The time given is 10 minutes, but you really don't require 10 minutes. You can do it maybe in a minute or two. There are only 6 multiple choice questions with one correct answer, only one correct answer per question. And each question carries the same marks, 1 mark, and there is no negative marking. All questions must be answered to submit the quiz. You cannot click on the submit button until all your questions are answered. And once you have submitted, the answers cannot be changed. Scores will be displayed. You'll be able to see your scores immediately once you complete the quiz. The top 3 scorers will receive certificates and prizes, which is an additional discount, like I said, for the maternal medicine course. And if you're already part of the course, then the support Pallavi will get in touch with you about what other options you have. But of course, you'll get your certificate. In case of a tie, the fastest responder will be selected. So we are going to show you a QR code. We are also going to show you a website link. And in the chat box later, we will add that. Not now, Pallavi. We will add it a little later once the quiz starts, and you have to enter your name and your email ID and then quickly answer those 6 questions, because we are not only going to see how many are correct to see who's the winner, but we are also going to consider who's the fastest. So if 2 people tie, the speed will be considered. The faster person will obviously score above. The price is a huge discount of 25% on the medicine course. That is, of course, by Dr. Lakshmi, Dr. Uma, and Dr. Hari. There's just one disclaimer. The quiz requires an active internet and data connection. So that is, if it's not there, then that nothing can be done. And the quiz organizers are not responsible for any technical issue during the quiz. This is just a fun thing we thought, would keep us active through the webinar and keep us, to make sure that we've remember and recollect all the interesting stuff that we got to hear today. So I hope everyone's ready. You can answer in the chat box if you are. If everyone's ready, we are going to start. Pallavi, please display. And after this quiz, we will, Dr. Lakshmi and Dr. Hari will answer all your queries. And then by that time, we should have the quiz results ready. So can I move on to my next slide? I hope everyone is ready. So it will come on to your, you can, this is the link. Pallavi's already given you the link. So please go ahead. And if you want, you can also scan the QR code, and you can also go to this link. So any of the 3 will be possible. You can look at the link in the chat box. You can copy this ID, or you can scan the QR code and write your name, write your email, and start answering those 6 questions, and then click on submit. Pallavi, can you reshare the link to the quiz both on Q&A in the Q&A box and in the chat box, please? Dr. Lakshmi, we'll wait for a few more minutes, and then Dr. Hari and Dr. Lakshmi, we'll wait another few minutes. Muted.
Yes, we can, once the quiz is completed, we have done some of the answers already in the Q&A box, but I think for the benefit of everybody, it will be helpful for us to go through them.
Yeah, sure. But
Yes.
we'll do that a little later. We'll just
Yes.
wait for them to
Sure.
finish just a few minutes.
Sure, sure.
Thank you. Hello. So though it says 10 minutes time to answer the quiz from when you start, we want it 10 minutes from when we gave you the link. So there are another 3 minutes left. In 3 minutes, after 3 minutes, we'll be closing the quiz.